welcome, welcome to everyone who's here at this honor reception, the second one we've had to hold virtually. I think we all miss being together in person. We hold this reception every year really to thank you, you and your family members for kind of allowing the Goizueta Alzheimer's Disease Research Center to do work that we hope is going to be beneficial for you and your family and others and other families who are living with illnesses like Alzheimer's and other dementias. So this is really a thank you for you. It's a time that we take to remember those who have been part of the research family, our research family, and who have passed on. It's also a time that we spend reporting back to you on work that a number of the investigators, just a small number of the investigators in the Goizueta Alzheimer's Disease Research Center, the work that they're conducting. There's an awful lot going on, but we've tried to highlight some very, very interesting pieces of work. It's also a time when we're going to continue to try to recruit you into research. Over the course of the hour and a half, you're going to be seeing some recruitment materials flash on the screen. We can provide you with more information about these opportunities, but we'll never pass up a chance to try to draw you even more deeply into research. And finally, it's going to be a chance to respond to your questions. At the end, a good deal of time is going to be spent enabling you to ask questions you might have of those of us in the panel, and we will try and provide the best information we can. I'm going to turn this over now to Drs. Hale and Parker for a remembrance ceremony. So Dr. Hale, Chad Hales, if you'll take over.
Thank you for joining us today for this time of remembrance. I had hoped that we would be back together again in person this year, but alas, not just yet. We continue to live in strange times, and in some respects, all of us have experienced some type of loss during the last year. Whether it be lost time with family and friends, loss of experiences that would normally shape us, or lost friends and loved ones to COVID, other illnesses, or Alzheimer's disease and other dementias. The year made us think more about impermanence and uncertainty as a continued way of life. Glimmers of hope, however, can already be seen. The cherry trees are starting to show their first blooms, despite the frigid temperatures. And the chirping in the trees seems to be increasing ever so little as daylight begins to extend ever more swiftly. Puxatawny Phil did not have good news this week from the groundhog world. 6 more weeks of winter. But it seems he's about as good as a coin flip when you look back over the years. So maybe, just maybe, some warmth is just around the corner. The other hope lies within you as supporting family members and our participants who have completed their journey. They understood the importance of advancing research so that hope can continue to grow for new discoveries and better treatments. We are grateful for their participation and know that they will be missed. Sometimes separating good memories with our loved ones from the effects and impacts of ailments and disease at the end of life can be hard. It's okay to acknowledge that, but this is also where we have the opportunity to recenter our thoughts on who they really were. I am certain it's what they would have wanted. In remembrance.
We pause now to remember and acknowledge our research volunteers. Naomi Bell, Carol Z. Daniel, Stanley Foster, Carol Gearing, Sarah Jin, Jerry Holiday, Mary Ann Milton, Lee Hayes Rogers, Dale Sessions, Charles Schaffer, Mary Ann Watson, Sue Weiland, Grace Williams. We are sad for the loss of each of our volunteers, but we are hopeful because they leave us with a legacy, and that is hope for a cure for this most disabling disease.
I think Thich Nhat Hanh, a teacher of compassion, mindfulness, and nonviolence, may have captured the essence of our brief time today in an excerpt from his writings. The words feel all the more poignant given his ultimate transcendence just 2 weeks ago. This body is not me. I am not limited by this body. I am life without boundaries. I have never been born, and I have never died. Look at the ocean and the sky filled with stars, manifestations from my wondrous true mind. Since before time, I have been free. Birth and death are only doors through which we pass, sacred thresholds on our journey. Birth and death are a game of hide and seek. So laugh with me. Hold my hand. Let us say goodbye. Say goodbye to meet again soon. We meet today. We will meet again tomorrow. We will meet at the source of every moment. We meet each other in all forms of life.
I want to thank Dr. Hales and Parker, Dr. Gearing. We really are immensely grateful for all of the volunteers to our research. And this is an effort to sort of celebrate the contribution that those who have passed have made to the science, to our center, and to all of you. So, so thank you. We want to get to the next part of the program, which is our report back to you of activities from the center. And I'm going to start by introducing the center's director, Dr. Allan Levey. So Allan, I think the stage is yours.
Thanks, Ken. Thank you all for joining this morning. It's really our privilege and recognition of your efforts and partnership with us to help us find a cure and to make progress and to help our ability to care for those who are affected. Thanks, Chad and Monica, for that, and Marla for the meaningful comments this morning. It's just such a reminder to see, those who we've lost this year. They continue to inspire us to do better. We have such a journey in front of us, and recognize how challenging it is for many of you and your families. So again, we can't make progress unless we do it together. And your involvement with our center has been fantastic. You're going to hear from some of our colleagues in just a few minutes. I just wanted to give a reflection about among all the activities ongoing in the field, Our center focuses on everything from caregiving research to understanding causes of these complex dementia syndromes, to developing new treatments, to educating the next generation and educating the public, making them aware of all the challenges so that we can continue and make rapid progress, as rapid as possible. Over this past year, I just want to highlight a couple of things from a higher level, and even some work from others around the world. Many of you, when you participate in research with us, this is a very collaborative community, and we can share, and we do share and collaborate with others around the world. Over the last 4 years, I had the great honor and privilege of serving on the National Advisory Plan we just celebrated the 10th year anniversary of the national plan to address Alzheimer's disease. And that plan has been making great progress. We've seen a tremendous increase in resources for all of us to accelerate the journey. Goal 1 has been to prevent and effectively treat Alzheimer's disease and related dementias by 2025. And you're going to hear more. I'm sure that there's been a lot going on this past year in this space. We also have to enhance care and quality and efficiency. And goal 3 is to expand supports for individuals and their caregivers. 4 is to enhance the public awareness and engagement. Goal 5 has been to improve data to track progress. So those are things that we all participate in, and your involvement in our research is essential for us to contribute to those national goals. The thing I am personally most proud of from my role on the committee was the last couple of years chairing the committee, was to bring forth a new 6th goal that has been adopted this year. And that's to accelerate action to promote healthy aging and reduce risk factors. All of us, if you participate with us, and those of you who see us in the clinics know that we've always been strong advocates for lifestyle. What are those lifestyle factors like exercise and diet and sleep hygiene that can promote healthy brains and provide resistance and resilience against the pathology of Alzheimer's disease and related disorders? So this is, I'm really, really pleased to see this get elevated to a national goal with more prominence so that it can start attaining some of the resources needed, just like the other goals. And just this past month, there was a fascinating article. It actually hasn't even been fully published yet. It came out in a preprint, as it's called, in a journal called Brain, one of the leading neurology journals, just recently. This is a study in Amsterdam. They studied over 70 of these identical twins that you can see in this picture. A really interesting study. And we know these are elderly twins. We know that after people reach age about 30 or so, even when they're cognitively normal, as these twins were or are, people, about a third of individuals will start developing the pathology of Alzheimer's disease. And what we expect is a preclinical state of the disease where there's very high risk it will progress to symptoms over the years ahead. What was fascinating about this study is shown in this image, that the top row here, they looked at PET scans. So these are these fancy brain imaging scans that many of you get if you're participating in some of the research studies. And what you're looking at are, on this top row, are one pair of the identical twins. And the brains here are being imaged with a way for us to envision the neurofibrillary tangles, or the tau pathology that accumulates. And here in twin 1, the left side of the brain doesn't have a lot. The right side of the brain, here you can see a lot of these red and yellow areas in the frontal parts of the brain and the temporal lobe regions that are so important in memory. There's a fair amount of of the neurofibrillary tangles that are already depositing in this twin. And again, this twin, it's pretty unusual distribution. It's far more prominent on the right side of the brain than the left. Here's their identical twin. Same pattern, very little on the left side, but quite a bit here in the same regions on the right. What was really quite remarkable is in these identical twins, the researchers could predict about 86% of the time which twins were related just based on looking at their PET scans. So there's this confirms what we've known for a long time. There's a very strong genetic basis to the disease. but it's really quite remarkable to see that it's so accurate even in a preclinical stage of the disease. But the really important, I think, exciting thing is that some twins showed that they had very different patterns of the neurofibrillary tangles in their brain. So this is another twin pair on the bottom row. And you can see in this twin, the red region here in the temporal lobe is where many of the neurofibrillary tangles are deposited at high level on both the left side of their brain here and on the right side. But in contrast, the identical twin had very different pattern, or very far less of the neurofibrillary tangles accumulating in their brain. And the teaser is the investigators began to search for the differences between the two twins. Since their genes are identical, what is it about their other factors, like the other factors that could account for this, such as their physical activity, whether they had depression, whether they're socially active. And you know, we all talk about those things, and you're involved in so much of the research with us to learn about those behaviors. And what they found is that those factors seem to be contributing to these differences. So very, very strong direct evidence that lifestyle and disease and modification of risk factors may actually be very important. So with that, I will stop sharing and turn it back over. And thank you again for all of your participation, and stay active.
Thanks, Al. That is a fascinating study.
Incredible.
Great combination of the emphasis we place on lifestyle activities. So that's terrific. I'm going to call on Dr. Jim Law next to give an update on his work and the work of the center. So Jim.
So that study highlights, Ken, why retirement is not good for our brain. So contemplate that as you go forward. Let me also welcome everybody. Thank you so much for joining us, and thank you for all you do. I'm going to start my screen sharing, I hope. And so what I want to do is provide a brief update in a couple of different areas. There's too much to cover. A lot has happened, but we just want to highlight a couple of key changes that have occurred. And then Dr. Hajjar is going to describe some new work that's been happening. But anyway, I just want to get us back on get us all on the same page, and I'll show some slides that I've showed many times, and I think some of these are going to be familiar to folks. But this is just a famous photograph of Auguste Dieter. Frau Dieter was the first patient who was described by Alois Alzheimer to have this disease that carries his name. And she actually is felt to be a really rare individual because she was so young when she developed symptoms. We now know that she actually carried a genetic mutation that caused her to have an early onset form of Alzheimer's disease. But nevertheless, after she died, this fellow studied her brain and described these pathologies that remain sort of well-recognized hallmark features of Alzheimer's disease even today. And Allan was referring to those tau tangles that were visualized on those special PET scans. And the other structure that you see in the center of this is something called an amyloid plaque. This structure right here. And those two things remain sort of well-recognized hallmarks of the disease. And I want to fast forward a little bit to some really important understandings that have come along in the last couple of decades. And that is that we've come to understand Alzheimer's disease as a chronic disease, chronic condition, no different from any other chronic condition, in that it is a process that builds up gradually over time. So people don't have heart attacks because all of a sudden they go from perfectly clean coronary arteries to nearly completely blocked coronary arteries overnight. This happens over a period of many years. And likewise, we've come to understand that the pathology of Alzheimer's disease, from the very early deposition of these amyloid plaques to the accumulation of neurofibrillary tangles to the development of degeneration and shrinkage of the brain, that's a long drawn out process that occurs over 15 to 20 years before individuals start to develop memory loss and gradual cognitive decline. And so this is a really important concept, because if we're dealing with a disease that has an average clinical course of 10 to 12 to 15 years, but there's a long prodromal preclinical phase of disease, this is where the prevention, the lifestyle, and also medications can potentially come into play to slow and hopefully eventually prevent the development of disease. And we know we can detect this. So some of you who are research volunteers have had spinal taps or lumbar punctures, which all sounds terrible. So I've decided we should call them something like lumbar tickles, because, you know, I have it done every couple of years, and after the numbing, it really doesn't hurt. So I think it just sounds awful. But the importance of doing that is because that spinal fluid, which we collect from down in the lower back, well below the end of the spinal cord, so there's no danger to that important structure. But that fluid is the same fluid that's in direct contact with our brain tissue, and we can measure proteins in that fluid that tell us whether or not we would see plaques and tangles inside the brain if we looked in the brain or pieces of the brain. And that allows us to do something really important. And so I said that those pathologies are evolving for 15 to 20 years before symptoms start. And we can detect the presence of those pathologies up to 15 to 20 years before any symptoms. The problem is, given the current tools, we don't know exactly where we are in this process. In somebody who's healthy, we don't know if they're right around the corner from developing memory loss or if they're decades away. And so that's an important challenge that we're facing right now that we're actively working on. And I bring that up because it's highly relevant to something that we're all going to be focusing on. Because the cure for Alzheimer's disease, and some of you have seen me share this slide before, when we're talking about Alzheimer's or any other dementing illness, the problem with the disease is that as disease progresses and things get worse, in later years of the disease, the level of impairment can be quite profound, and the impact on the quality of life can be very, very poor. But in early stages, in mild cognitive impairment and mild dementia stages, quality of life can remain very good. And so the idea behind disease-modifying therapies is if we develop interventions that can be used somewhere early in the course of this, we can slow things down enough. And if we do that sufficiently well, in order to ever reach these late stages of disease, we'd have to live a very, very long time. And since we're all going to die of something, if we can die of whatever it is we're going to die of before we reach these stages, that, in my mind, is the equivalent of a cure, because we will have avoided the ravages of the worst stages of this disease. And so going all the way back to Alzheimer and the description of these amyloid plaques, one of the important ideas is if the plaques actually play a central role in causing disease, we should be able to ameliorate the disease by modifying the development and accumulation of those amyloid plaques. And that's exactly what's been happening. That's been the focus of a lot of therapeutic development in research and in big pharmaceutical companies over the last 20 years. And many of you have heard about the controversial approval of a drug called aducanumab. And this is a very controversial, very complicated topic. We're still struggling with it. But the promise of this drug and other drugs like it, this is now an amyloid PET scan. So these warmer colors show where the amyloid pathology is in these three individuals' brains. And in people who were treated with a placebo after a year, the pathology looks about the same. But the exciting thing about early studies of this drug was that there was a dose-dependent elimination of amyloid pathology. So after a year of high-dose treatment, the amyloid basically was cleared out of the brain. And that's been consistent. We've seen that consistently with this drug and with other drugs that are similar to it. The excitement with aducanumab, and I think I actually copied this slide from an honor presentation from 3 or 4 years ago. But the excitement from this study was that it appeared to also slow the progression of disease. So that was several years ago. And now this drug has moved all the way through the very large phase 3 clinical trials. And it again consistently eliminated the amyloid pathology And in one of the two large trials, the people who received the highest dose of the drug actually had a significant slowing of their disease progression. The problem is that the second very large trial did not show any benefit. So this is where things stand in terms, this is the crux of the controversy right now, is that normally you expect two different studies to show the same thing if the drug is going to have efficacy. And the further complication is that up to 40% of individuals who participated in these trials developed a type of amyloid-related abnormality. So these whitish patches here, which were not present at the baseline scan, these represent areas of swelling that was associated with use of these anti-amyloid antibodies. And then in other instances, these little dark circles here, dark spots, represent areas of microscopic hemorrhage. In most instances, these were not clinically relevant, and they were detected by imaging, and drugs could be held, and so people didn't get into a lot of trouble with them. But this poses a very serious hazard. We're talking about swelling and bleeding in the brain occurring in up to 40% of individuals. So with the limited evidence for benefit and the significant evidence of potential risk, this is that's the sort of foundation for a very controversial use of this drug. There are some pros. This is obviously for Alzheimer's disease. It's an enormous unmet need, and the value of providing hope to patients and families and those who are concerned is not to be underestimated. All the other drugs that we currently have may provide very modest symptomatic benefit, but cannot slow the progression. And so slowing of disease progression holds the promise of having greater impact over time. And as controversial as it has been, the process that FDA used to approve this drug may be applied similarly to other drugs and may accelerate approval and accessibility. As I mentioned, there are very significant risks, very limited evidence for clinical benefit. Initially, the drug was priced at $56,000 a year, and there are all these ancillary costs associated with diagnostic testing. And an important issue related to disparities, as many of you know, we have focused attention at our center here at Emory for many years on health disparities. And it may not shock you to know that there were a grand total of 6 African-American participants in those 2 huge clinical trials who received potentially effective doses of the drug. So in essence, we don't know whether this drug is going to be beneficial, more harmful, less harmful, more dangerous, less dangerous among African-Americans, because pretty much everybody in these studies were not Hispanic whites. Nevertheless, this advance this past year represents a very significant step in the process that we are taking to actually deliver more effective disease modifying and preventing treatments for Alzheimer's disease. So I'm going to hand the presentation over to Dr. Hajjar to describe another really exciting development.
Thanks, Dr. Law. So I'm Ihab Hajjar. I'm one of the providers at the Cognitive Clinic and the director of the clinical trial program in our center. I wanted to share with you an important study that focuses on the same theme that we have been talking about this morning, which is preventing people from reaching the stage of symptoms or symptomatic disease, especially people who are at risk of developing Alzheimer's disease. So this is a national or an international actually effort that is led by the National Institute of Health in collaboration with industry to treat people who are considered at risk of developing Alzheimer's disease by the mere fact either that they have family history or other risk factors, and see if we give them a treatment that will prevent the accumulation of the protein that Dr. Law and Dr. Levey have been talking about this morning, the main protein in the plaques. If we are able to stop the brain from accumulating these proteins, are we able to prevent people from going from the asymptomatic phase of the disease to the symptomatic phase of the disease? This is a relatively new study that kind of started around the time where the pandemic started, so you might have not heard about the effort. So we thought this would be a good opportunity for you to be aware of this as an opportunity for you to participate. The main objective, as I mentioned, is to test the question is that if we give treatment that is very similar to aducanumab, although it's not an aducanumab study, it's a band 2401, which is a cousin, I guess, of aducanumab, has the same effect. And the idea is that if we give people for a while this medication, that we are able to prevent them from going into the symptomatic phase. It is rather an intensive study, but this disease is very disabling, so the treatment is going to be as intensive. It requires a commitment of few years. You will be receiving, or the participants will be receiving the intravenous medication every 2 or 4 weeks. It kind of slows down as the time progresses. And it includes a lot of the procedures that a lot of people who participate in our trials or in our studies are familiar with. It was a cognitive testing or a memory test, a brain scan, and an amyloid and tau PET, which you have seen a few images this morning about. The issue of the lumbar puncture is optional. So in order to additionally assess the presence or decrease of the amyloid level, people will be offered to have the spinal fluid assessment as part of their test. Quick comment on who are eligible. As I mentioned, these are individuals. People who are eligible for this study are individuals who are considered at risk of future Alzheimer's, but they're currently without any symptoms. And in this specific study, these are defined as anyone who is 65 years or older. So the mere fact that as we get older, we are at increased risk of Alzheimer's disease and dementia, that is by itself considered a risk, and therefore would be qualify the person to be in the study. For the younger group of people, and in this study, excuse me, we define those as those who are between the age of 55 and 64. One is considered a higher risk if they have a first-degree relative with dementia that has started before the age of 75. If they have known the genetic risk factor, which is called ApoE4. How do people get ApoE4? A lot of times it's either by participating in other studies, or if they've had any ancestry or DNA testing, you might get that information from like commercial entities like 23andMe, etc. And then the third, if a person has had by either clinical or research-related PET scan, and they have been told that there is evidence of amyloid on their PET. And finally, if you are interested, or you know of somebody that might be interested, I put here the 2 key contacts. You can either email me with that information, or you can either also chat or send a queue in privately here, or you can email our study coordinator, Latasha Chapman. And I'll hand it over back to Dr. Law.
So really an exciting study, and again, there's been another previous prevention trial, which we hope to hear results from shortly, and this one is a really promising one, as it's dealing with a 2nd generation or 3rd generation anti-amyloid therapeutic. So with that, I'm going to hand it back over to Ken to continue with our program, and I think we'll all be available for any questions at the end of the program. Hopefully there will be some time.
Thanks, Jim, and yeah, those are great presentations, and that was one of the best presentations of the aducanumab story that I've heard. Really nice, detailed and balanced presentation of a complicated story. So I said that at the beginning that the center conducts a very, very wide range of research, and what you've heard over the last 20 minutes is kind of the very kind of basic brain stuff that a lot of the scientists do here. We're interested in lots and lots of issues related to aging, and our next presenter, Dr. Antone Trammell, is going to talk about a fascinating study of people who, in fact, age extremely well and about whom we need to know more. So I'm going to turn it over to Dr. Trammell and tell us about the Superager study.
Good morning, everyone. I'm Antone Trammell. I appreciate your gracious introduction, and I'm really excited to be here with all of you this morning. It's a beautiful winter morning. So I'm going to talk about a planned study on superagers, and I'd like to take a moment to acknowledge my colleagues, Dr. Monica Parker, Dr. Felicia Goldstein, and Dr. Ihab Hajjar. They've been very instrumental in helping me get this study going, and we're going to do some great things. All right, what is a superager? So despite the name, it's not an older adult with superpowers or some other supernatural ability who's fighting crime and beating up criminals. But a superager could be each and every one of you. And if that's your goal, I want to help you achieve it. We want to help you achieve it. And hopefully, I will be in your company in that process. So a superager is an adult who's 80 years or older with cognitive resilience. What is cognitive resilience? That's the ability to maintain your memory and thinking despite aging and related changes in your brain. Also, a superager has memory tests that are similar to a person who is 50 to 60 years younger. So there's a difference between the chronological age and their biological age. A great example of cognitive resilience, maintaining your memory and thinking despite aging and related changes, is the NUN study. So in this study, very fascinating, they looked at 678 nuns. They ranged in age from 75 to 107. They agreed to donate their brains after death. And this allowed the researchers to compare their brains with their memory and thinking while they were alive. And what they found at autopsy is that their brains ranged in disease from severe Alzheimer's to damage from high blood pressure and strokes to nothing at all. So essentially, the brain findings did not always match their cognition in real life. Thus, it's possible to maintain the mind despite disease in the brain. Well, the question is, why? And that's exactly the question that we hope to answer. So, due to generous funding from the Alzheimer's Disease Research Center and the NIH-NIA, my colleagues and I are planning this study to look at factors related to successful cognitive aging. We also hope to try to get an idea of just how many people in the Metro Atlanta area are walking around as superagers. That would be really great to know. And what makes them a superager? Unfortunately, a lot of studies in Alzheimer's disease and related dementias, period, have very limited racial composition in their samples. And the Alzheimer's Association and the research community is aware of this. To address that problem, we aim to recruit a diverse research sample. What can you expect if you are interested? Well, memory and thinking tests or tests of your cognition, some blood draws, brain scan with an MRI, the lumbar tickle or spinal tap, as Dr. Law mentioned, and you'll be followed for several years. What are our goals? We want to learn the factors, the potential factors that are related to successful cognitive aging in a diverse sample. If disease affects an entire population, people of different backgrounds, it's important to look at the disease in people of different backgrounds so that you can develop treatments and interventions of some form that work in people of different backgrounds. To that end, we're looking at lifestyle. We're looking at your demography, your health history. A host of factors will be explored. And hopefully we can find some interventions, some things that will help us achieve the goal of all becoming superagers while enhancing minority representation in dementia research. So again, if you're interested, we hope to take participants by the spring of 2022, this spring, just a few months away. We're compiling a list of interested individuals. You can contact me. Please just by email, it's preferred, just put superager in the email subject line. You can also give me a call. Happy to have conversations with you. And I look forward to meeting more people, and we're excited to move the study forward. Here's my contact information again. Right, my first name, last name at emory.edu. There's a phone number, and please just put Superager study in the subject line.
Thank you, Dr. Trammell. Dr. Parker has asked the question if one is already 80 and in the Emory Healthy Brain Study or another study here, can they also participate in the Superager study?
Dr. Law beat me to the punch. Yes, absolutely.
Okay. So
The only caveat is that the study does not, the eligibility requires that people don't have any cognitive issues to start with.
right. So as promised, we're going to bring a number of the panelists back to answer questions that may have arisen for you in the course of the presentations. Now, everybody has been living on Zoom for the last 2 years, so you know that if you want to ask a question, you type it into the chat or into the Q&A, and we can read them. We'll read them aloud. So anybody have some questions, start entering them into the chat. And until we get some questions, I wonder if the panelists have things they would like to add to their presentations or other points to make to the group.
You know, I just want to point out that one of the focus areas that we've had for quite a while now is the development and evaluation of new biomarkers, and biomarkers being anything that can serve as a sort of a surrogate based on a laboratory test or imaging test that will tell us about disease in an important way. And the AHEAD study and other prevention trials really highlights the importance of that effort, because the recruitment for these prevention trials is a bit tenuous, and the reason they have to go on for so long, 4-year commitment, is because unfortunately, the proof of the pudding in prevention is going to be proving that the treatment is actually effective at either delaying or preventing the development of early Alzheimer's symptoms compared to placebo, which means that some people in the course of the study will have to develop symptoms. If we can develop surrogate markers that allow us to accurately predict when or if people are going to develop symptoms, and those are effective surrogates, that will tremendously shorten the duration of time and the potential risk for participants, as well as making the efficiency of the studies much greater. So when we ask you to participate in these studies where you're providing us opportunity to scan your brains, collect your spinal fluid, collect your blood, those are all intended in part, that we do other things as well, but a large focus of what we've been doing is doing exactly that, trying to identify ways to predict both symptoms and timing of symptoms.
I also want to add that there is hope that in the next couple of years, we will evolve more in the biomarker area and we'll have blood tests. So the hope is that not always, or it's not a mandatory thing to have a lumbar tickle, I guess, to have the biomarker assessment. And the AHEAD study actually has recently implemented a way to measure some of the blood tests to determine whether a person is eligible or not. It is not going to replace the PET scan or the spinal fluid, but it's at least, if it proves to be successful, I think this is very hopeful and encouraging, and that we will be able to have a blood test before we, in the next few years, a couple of years, to have this, or maybe sooner even.
I'd just like to add to both of those, which are both so really important comments from Ihab and Jim, is that there's a whole new area of biomarkers that we're also beginning to really invest in, and I'm sure you'll all learn more about, called digital biomarkers. And this is the idea that we can, right now, for example, many of you get these pencil and paper tests as our best way to assess cognition. What we're learning is that there may be ways that are far more sensitive for us to accurately measure very subtle changes in our memory and thinking abilities. Just using tests that are administered on like an iPad, for example, or through a smartphone, or listening to somebody speak. Even just listening to speech patterns has great potential to provide clues to whether there are cognitive changes. So those are new elements of the types of assessments that we'll be doing in the years ahead, including digital technologies to help us measure sleep, for example, or physical activity. So again, we really embrace your participation because the world's changing rapidly and we're glad to play a leading role in it.
I do want to point out that there's an active chat going on, and Dr. Trammell clarified that the age requirement for the Superager study is 80 or above. And there is a question about whether the center is working on any vaccines for to prevent Alzheimer's. I suppose, Jim, you might want to take that.
Well, actually, I'm going to let Ihab take that because
Yeah,
that's
actually, yeah, that'd be fine. So we have 2 studies in the pipeline that are in various stages of maturity. One is in collaboration with a startup that is trying to take the amyloid plaque, that protein that is in the plaque that you guys have seen earlier, and incubated with some of a person's T cells or immune cells, and then reinfuse them back. It's called active vaccination, I guess. So this study is in the process. The COVID has really put a full halt on that study, so we're not sure when that's going to be started. And then there's another study, a multi-center study that we are in the process of negotiating whether we will participate in or not, that about a different type of vaccine. We have not gotten the full details, but be on the lookout for those 2 studies. They hopefully will be announced later this year.
And I just want to add that even though, we tend to think about vaccines like the jabs that we get for COVID vaccine and flu shot and things like that, the treatments that are currently in these later stages of testing and aducanumab are really passive vaccines. So the monoclonal antibodies that you hear about for treatment of COVID is a form of a vaccine. It's preformed antibodies that are being put into the body to try and eliminate the virus. And these infusion studies of the monoclonal antibodies, whether it's the BAN 2401 in the HEAD 345 study, or the aducanumab, those are forms of vaccinations as well. And there are 2 additional drugs besides those 2 that are also in the pipeline. So this is something that is coming, and so it's really, there's a lot to be done yet, but it's a really exciting time.
There are a couple of comments or questions I wonder if you all could address. One is if Marla Gearing could talk about brain autopsy and the procedures and what happens in brain autopsy. And the other question somebody can prepare an answer to is, you've all talked about the lumbar tickle. What about the MRI procedure? What's that like? What's it like to go through an MRI? You get a break and.
Terrific. So for us and for participating in the autopsy program, we do require that people have at least 1 research visit with us. Clearly, most of you fall into that category if you're already part of the cohort, but it's ideally, we'd like to know ahead of time that you're willing to participate so we have some idea and we can gather information about who your next of kin is so that we know who to reach out to. We'd like to have some of this information in place ahead of time so that your family isn't burdened. As you near time of death, we know it's a very traumatic time for the family. And so ideally, we like to have some of that information ahead of time. State of Georgia is very interesting. You cannot give away your own brain. Your next of kin would do that. So at time of death, the consent form would be filled out. So if you're interested in more information or haven't heard yet about it, please do feel free to reach out to me, to Dr. Gearing, or to Sam Heldenberg, who you probably know through communications about your study visits.
And
There was
the
a question about the price of Educator Map, and it started off, I think, about 65,000, and now in the last few months, it was reduced to, I believe, $28,000, something like around those numbers.
And just a brief comment on that, that particular number is kind of floating around, right? We have no idea what the actual cost might be from an insurance perspective. And also that number is just for the drug costs. So there are costs for MRIs, clinic visits, infusion center. There's a lot of hidden costs that are also in there.
Yeah, I'll just add to that, since it's such an important topic, and I know it's on everybody's minds and in the press all the time. Because of all the controversy, this continues to change, but we know that CMS is going to be making a final decision soon, and very likely there will have to be ongoing clinical studies, and that through enrollment in clinical trials like we've been discussing this morning, some people may be able to access in Medicare. CMS will actually pay for it in that situation, so it won't be out-of-pocket costs.
Yeah, that has, it's a good thing. A lot of people, including the Alzheimer's Association, were furious about Medicare's decision about that. But I actually think that it was a very well-reasoned preliminary decision. That said, it has greatly complicated our lives. Dr. Hales and I have been working on trying to figure out what the process would be if Emory were to agree to allow treatment of our patients with aducanumab. And now we have to figure out exactly what it means based on Medicare's decision, what it means to be receiving the drug as part of a clinical study. So I have been actively investigating that. There's some precedents that we can use, but it's a lot to work through yet. And Dr. Hales answered in the chat, Ken, about the MRI scan. Chad, do you want to just go ahead and answer that for everybody?
Yeah, sure. So MRI scan, the session usually lasts from 45 minutes to over an hour, depending on the number of individual sequences within the MRI. So when individual sequences are ongoing, those can last several minutes at a time. And during that time, you have to be very still. But in between those little few minute segments, you're allowed to kind of shift and move around, and the technician will let you know when that's okay.
One additional comment about the MRIs, which we experience, rather frequently, I would say, is the issue of being claustrophobic, because you go inside that tube, and there are ways to minimize that in our center and others, including some medication that can be given. So if that's an issue, please, discuss with the coordinator that's talking to you or with your doctor about this.
Yeah, we have done, so for those participants who are because it is, I had mine not long ago, and the scanner is designed the way it is to give us the most perfect pictures of the brain that we can get. But it makes it, the smaller the bore, the better. So you're in that thing, and the thing is like right in front of your face for 40 minutes or more. So it is a pretty tight spot. I just fall asleep, but if you tend to be anxious and claustrophobic, it can be quite difficult. And I can't really prescribe medications for people who are not my patients, but that's something that you could request of your provider if you know that that's going to be a problem for you. So there was a question in the chat about candidate for MRI, if you have any metal in your body. It depends, like joints and artificial hips and things like that are made of titanium are not an issue. The ones that we have problems with is if you have something that's going to be affected by the magnet, whether it's a pacemaker or a defibrillator, or some type of stimulator that's implanted, or if there's, if you're carrying around shrapnel from your time in battle that's going to move in the magnet, that's potentially a problem. But the most common source of concern about metal is joint replacement, and those titanium things do not cause problems and they're fixed and they're not going anywhere. Dr. Ihab, there's a question in the Q&A from Ms. Joyner about the vascular study, whether that's ongoing.
Yes, vascular is still ongoing. We are, obviously, as most studies in our center and everywhere, the pandemic has caused quite a delay in follow-ups. So we've caught up on a little on the, as you had in 2020, and you will be contacted 12 months after that. So probably if you have not heard from us, we will contact you soon to schedule a follow-up visit. There's also a question about the Cedar study. The Cedar study has actually concluded. We are awaiting the journal to review our paper, and the plan is once we hear back if it's going to be accepted, we are planning to set up a session to share with all the participants and others who are interested our key results. We just not allowed to do that prior to publication because journals don't like us to release data or results before it's published. So be on the lookout for that. Again, the pandemic has caused delays in reviews. It's been under review for about 4 months now. So
come on, Ihab, you gotta give more than that. Are you encouraged by the results?
Oh, okay. Yeah.
Nobody on this program is going to turn you in.
So you will not repeat that, okay? All right. So the Cedar study, if you're not familiar with it, is a study that we started here 3 years ago, I think, or a little more. And that's looking at the use of antihypertensive called candesartan in people who do not have high blood pressure, because we have shown before that in people with high blood pressure, candesartan prevents people from having further cognitive decline. We wanted to test it in non-hypertensive individuals to see if it actually can be used in patients who have prodromal or the early stages of Alzheimer's disease. And what we found is, one, it has a significant effect on lowering the accumulation of the amyloid protein in the cerebrospinal fluid. And also it also has a positive cognitive effect where people had a slightly better memory after 1 year of treatment. So this is the kind of a summary of the results, but we'll definitely share more later.
We can also disclose the results for those who don't know. Many participated years ago in a study we did repurposing a drug called atomoxetine. So similar to candesartan, these are drugs which are already approved for other indications. And we're all interested in these because it's an accelerated pathway if we can demonstrate benefits. And so the results of that study were just published last month in the journal Brain. So many of the team participated in this over many years, and it showed also very promising effects in that there was a reduction in spinal fluid tau, the p-tau, that is a measure of the neurofibrillary tangles and neurodegeneration. And so it seemed to have some potential benefits on reducing that, as well as increasing brain activity in imaging studies. So
at the risk of being the wet blanket here, I just want to make sure that we don't go overboard because these drugs are already FDA approved. I don't want everybody running to their doctor and demanding prescriptions for candesartan and atomoxetine. These are very encouraging early results, and I'm going to put Dr. Hajjar on the spot because I'm going to point out that given these very encouraging early results, it's contingent on us to expand on those smaller studies to larger clinical trials to really establish the kind of proof, the kind of proof that aducanumab has suffered for having failed to provide, but to prove that level of benefit so that people can start using these things with confidence that they do what we hope they're going to do.
Absolutely.
So as leader of our clinical trials unit, Dr. Hajjar is on point on that. So if it develops too slowly, you send him an email.
Yeah, I mean, I think that's an important point to mention is that a lot of these single center studies are small studies, but that's how the program, the treatment recommendation is built. You start off with small studies and then you start expanding slowly. So I don't think that we are at any point to say that these drugs are indicated for the treatment of Alzheimer's disease. However, I think these are encouraging data that hopefully future studies will further confirm. I have to say one thing about candesartan, though, that I think it is a drug for hypertension. So in individuals, I think, who have high blood pressure, who are having poor blood pressure control or are kind of starting on new medication, I think using a medication like candesartan might have a positive effect on blood pressure as well as on cognition.
For those of you who have been attending these honor receptions over the years, I think there's a clear understanding that the science is moving forward. It's moving forward in encouraging ways, but it's careful and it takes time. And to achieve the goal that Dr. Levey talked about of really finding, and the goal of the center to find a cure for Alzheimer's is something that takes a while, a long time. But in the meantime, families are living with this illness. And there's also work at the center that's being done that attends to the reality of family life and family caregiving. And we want to remind you that there are also a bunch of studies open now and that have been completed that are also looking at this other side of Alzheimer's and related disorders. So I think at some point we'll show you some sort of posters for that, but I do want to just mention that we have a very balanced portfolio of work at the center. Science is really where the sort of true excitement is at, but daily life is kind of where caregiving and those of you attending this seminar are living. So we're covering both parts.
Dr. Goldstein, is there any efficacy with brain games like Lumosity or any of those?
The evidence isn't really very strong that brain games by themselves, the computer games, are have much efficacy. What we would recommend, if you want to, they're engaging, they're stimulating to do, but they really need to be paired with other lifestyle interventions such as diet and exercise and stress reduction techniques. So by themselves, there's not strong evidence. And the other thing about the brain games is it's been hard to demonstrate that they really generalize to the real world. So you might get better at playing the game itself, but then if you want to go into the real world and remember someone's name, that might be difficult to transition to. So I really recommend some of these other more efficacy-based, evidence-based approaches that are really showing tremendous potential. So that's really the answer for that, I think. I don't know if the other panelists want to weigh in at all about that.
I'll just respond. Gary asked a question about this brain game called Wordle, which I don't know, but I just don't want you to disincentivize it. Gary, if you enjoy playing it, it ain't going to hurt you. So go.
It can't. No, it won't hurt to do them, but I don't think that they should be done just by themselves. I think you need to combine them with some other interventions as well.
And just to add a squishy bit to the science, even though I was trained as a hard scientist, but the part that I've become increasingly fascinated with is the evidence that it's not just activities or doing calculations or games or things like that, but engaging in activities that continue to provide you with a sense of engagement and purpose. And and it's sort of a nebulous notion, but I think that we all know what that means when we feel like we're engaging in something that we're passionate about, that really has meaning for us, and that really seems to carry substantial weight. And so, if you're retired, and you're not getting that regular stimulation, contribute, do things that that continue to provide you with a sense of place and purpose and engagement. And sitting at the computer and doing a game because you think it's going to help your brain is not my top choice either.
I agree, Jim. Yeah, doing something that really challenges you has been shown to be important for cognitive stimulation, and also something that you enjoy. So if you don't enjoy bridge, don't take bridge classes because you're not going to stick with it. But if you want to learn a new language or some other skill that or take up the piano again because you did it as a child but gave it up, those are the sorts of things that are fun and likely to keep you engaged.
And there's a pretty good literature suggesting that volunteering is very positive for cognition and brain health.
Also, I think one of the key kind of concept that has been evolving over the last few years is that there's not going to be a single, kind of single intervention or single drug or single thing that's going to impact the brain cognitive, function. It's been shown, like even in the finger trial, if you're familiar with the finger trial, is the multi-component interventions of lifestyle. And when you look at a single intervention like diet alone or exercise alone or even medication, single medication, you may not get the full benefit of having a more comprehensive multi-component program. So I think all of these mentioned are on the table in terms of if you want to have a considerable significant effect on cognition.
Well, let's see if there are no further questions. It doesn't look as though there are. I want to thank everyone for joining us today in this remembrance and acknowledgement of your tremendous contribution to Alzheimer's research. And I hope that we see you again next year, and then we have even more positive things to report then. So I'm going to turn it back to Cornelia in case there are other housekeeping things, and otherwise, thank you and say goodbye.
Thank you so much. There will be a survey link that you will receive in your inbox once you close out the program. Please take a few moments to complete that survey. And this session is being recorded, so we will send out a link to the recording so you can watch it again and share it with others. Thank you for joining.
Take care, everyone.
Bye now.
Thank you.